Good morning. First off, I have to say that it's quite nerve-wracking talking right after two of the giants in the field and my personal heroes, and one of them happens to be my boss. So I'm going to try my best. So you just listened to Dr. Baker talk about the importance of same-day ART and how it would be crucial to curtail the epidemic in South Africa. My talk today will focus on how we are currently doing same-day ART here in this setting at the Thai Red Cross Anonymous Clinic. So this is an outline of my talk. I will start off by giving you a brief background of the clinic, followed by the criteria and the protocol that we are currently using, and I will conclude my presentation with the current data and challenges we have encountered. So the Anonymous Clinic was established in 1991, the year I was born. So it has been operating for a little over 26 years. It was the first HIV testing center in Asia offering anonymous HIV and STI setting. Some of the services provided at the Anonymous Clinic, in addition to anti-HIV testing, include viral load and CD4 testing, HIV drug resistance, hepatitis A, B, and C. We also offer pre-exposure prophylaxis, post-exposure prophylaxis, as well as ARV medications. But we're not a hospital. That means that we don't have a lot of the equipment that you normally find in a hospital. And all of the clients at the Anonymous Clinic are outpatients. So if our clients are presented with symptoms beyond the scope of STI and HIV, we refer them out to be investigated further at a hospital. And this is an important thing to remember, especially regarding clinical screening to start ART. Just to give you a sense of the capacity that the Anonymous Clinic operates, last year we had about 35,000 people who came and got tested for HIV. 93% of those tested negative, and about 7% tested positive. We had about 28,500 people came and received ARV medications from us. About 1,100 purchased post-exposure prophylaxis, and about 535 bought prepped from us. So what is same day? How do we define same day ART? And I actually borrowed this definition from Dr. Diane Heffler, who was kind enough to gave us the protocol of the same-day ART at the San Francisco General Hospital. So same-day ART is a process of offering ART to newly diagnosed or newly re-engaged patients on the day of their HIV diagnosis or re-engagement. And if we couldn't do this within the same-day time period, we try to do it no later than 72 hours. So why are we doing this? So we are implementing same-day to see if there is any benefit to the clinical and or practical aspect of same-day ART, as well as to see if what we are doing here is feasible to other settings when we want to scale this up. Because we're not a hospital, what are our roles in same-day ART? So the Anonymous Clinic serves as an ART hub, and what that means is that we screen for eligible patients, and I will talk a little bit more what being eligible means. And we also conducted all the necessary baseline lab tests, and if everything looks normal, we initiate ART for 2 to 3 months, which is a short term, hoping that this would give enough time for the patients to continue the treatment at their preferred long-term care service site. Unlike the traditional way of starting ART, we decentralized the task of initiating treatment. This way, the workload is not so burdensome to only a few health workers. This actually allows us to create a system where we can support our clients during one of their most difficult times holistically. So in addition to the counselor, the nurse, and the physician that we are familiar with, we actually created a specific special position for this program called the navigator, whose primary responsibility is to help the patients navigating through their new life journey, including providing ongoing care support and linking them to the long-term care site. So our algorithm at the Anonymous Clinic is based on the Thailand national guidelines. So the ART we used is the first-line drug that Dr. Kiat mentioned this morning, which is FTC, TDF, and FL variants. And these are all the baseline lab tests that we had to conduct. One thing to note is that not all of the results from these tests are available during the first visit, and that is okay for most cases. We just need to know the confirmatory anti-HIV test as well as the result from the chest X-ray. So not everyone will be eligible to start ART on the day of their HIV diagnosis. The patients have to be willing to start ART. They cannot have any history of using ART, and they have to be able to come back for the follow-up visits to receive the results from their baseline test. So if we suspect that the patients have TB or cryptococcal meningitis or any other serious opportunistic infections, we do delay the HIV treatment and refer them out to be investigated further. So did we have any concerns about early ART initiation? Absolutely. These are the main concerns that we had, and a lot of the doctors that we talked to actually were primarily concerned with the patient readiness. IRIS was also something that we took into consideration a great deal when drafting the protocol. TB is quite prevalent here in Thailand, and we also have to be concerned with any IRIS associated with CNS, especially cryptococcal meningitis. So in the next set of slides, I will talk about the steps that we take to maximize the safety of ART initiation, as well as how we manage these concerns. So we divide the patient readiness into two parts, the pre-ART initiation and the post-ART initiation. We have two teams dedicated specifically to assess and support the psychosocial and emotional needs. The counselor provides post-test counseling, which is the immediate support right after the seropositive HIV result has been notified. And the navigators comprised of social workers, the members from the key population community, and the members from the people living with HIV community. And these people, the navigators, provide an ongoing support for our clients. So one of the most important steps is to assess psychosocial readiness. This is normally done by both the navigators and the counselor. Our team discusses the issue of disclosing their HIV status, as well as the potential impact that this may have on the friends, the family, and the employer, which seems to be the most concerning aspect of status disclosure among our patients. Right, and we also talk about identifying the person or persons in their life that they trust and can disclose this sensitive information to, so that they have that familiar face or faces that could support them throughout this journey. Our patients will also receive information of support groups that they could join. We actually have one PLHIV specific support group on site that has been a great partner for years. So all the communication between our staff and the patient is conducted in a non-coercive way. We discuss both about the benefits and potential risks, and this include common side effects and common OIs that ART may cause, and how the patients should manage them, as well as some red flag symptoms that if they occur, we urge them to seek medical attention immediately. We also really emphasize on the dangers and risks of disrupting or discontinuing ART. We also help our patients create the long-term care plan. We actually adapt this method from the life step adherence, which was developed by the team of Dr. Steven Saffron at the University of Miami. However, the bottom line is that the decision to start ART depends on the patients themselves, and if they're not ready, we will refer them out to the support group they could join. But if they're ready and we can initiate their treatment, we will contact them 1 to 2 days after ART initiation, as well as 1, 3, 6, and 12 months after to see if they have any side effect of ART, ask them how they are doing physically and mentally, as well as asking if they have any issues taking their medications. The Navigator team actually have this application called Line, which is a chatting application really common and popular in Thailand, as that serves as the main channel for our team to communicate with the patients and in case they need anything or any help from us. So as you can see, we do have very thorough and comprehensive steps to ensure that our patients are ready to start ART. But even if they're not ready, we do make sure that they get all the attention and care that they need. Another big concern for us is IRIS, especially TB and cryptococcal meningitis. And this is a protocol that we use to screen TB and other serious illnesses. So everyone must receive chest X-ray as part of the guidelines. And we also use chest X-ray as a way for us to pre-screen for pulmonary TB. And in addition to chest X-ray, we also use Gene Expert to help us detect pulmonary TB among those of the patients who presented with indicative symptoms, which are anomaly results from chest X-ray, persistent coughing, and coughing up with blood. So any one of these symptoms, we will send them to get Gene Expert. We will also use symptomatic screening for serious illnesses. And if the patients have all of these following illnesses, fever, unexplained weight loss, and CD4 less than 100, all of these three, we will delay the treatment and refer them out for further investigation. However, the bottom line is using the physician's clinical judgment is one of the best tools to decide whether or not ART should be initiated right away. And this is the protocol for cryptococcal meningitis. During the physical examination and medical history assessment, we look for signs that would indicate meningitis. And for all of the patients with CD4 less than 100, we test for cryptococcal antigen. And if the test comes back positive, we will refer them out for examination and treatment. And this is the overview of the same-day program at the Anonymous Clinic. We have 4 visits total, and I've also highlighted the visits where the patients will receive ART, which are visit 1, 3, and 4. Like I said, we divided same-day ART into 2 phases, the pre-ART initiation and the post-ART initiation. And these are all the processes and the steps in each phase, and also the 4 key players that I have already mentioned. So I'll start with same-day ART and see what we actually do in each visit. So the first visit, after the patient tests positive for HIV, and they would go and see the counselor. The counselor would notify them of the status, conduct post-test counseling, and this is when the counselor actually introduces same-day ART service and assess their eligibility. And then again, the 2 exclusion criteria here are history of ART and cannot come back for the follow-up visits. But if the patients are eligible and willing to start, the counselor will order the confirmatory HIV test and CD4 count, as well as blood collection for the baseline test and chest X-ray. One thing I forgot to tell you that when we notify them of the first HIV status, that is the only first test. We also do 2 additional tests to confirm that they indeed have HIV. Then the patients will go see the navigator who will assess if the patient have indicative symptoms for pulmonary TB and to see if we actually do need gene expert in addition to chest X-ray before getting their blood drawn. The waiting period for the confirmatory HIV test and the CD4 is about 2 hours, which is enough time for the patients to go and get their chest X-ray and gene expert at a nearby hospital that we partner with. So after having the results from chest X-ray and anti-HIV confirmatory test, we move on to steps 2, which the navigator will verify the results, assess psychosocial and emotional needs, as well as conduct adherence counseling and exchange the information contact. And like Dr. Nitya said, that it is not uncommon for residents in Bangkok to have their registered hospital according to their health insurance in another city. So what the navigators will do is they would assess the eligibility of the health insurance. They will discuss of the preferred location of the hospital for long-term care support, and if needed, we will then initiate the transferring process. Next, the patients will go see the nurse who will notify them of the CD4 results and conduct the medical history assessment that may indicate any other serious OIs. One thing to note is that CD4 results are not always available during the first visit. And if this is the case, we will call them back for those who have CD4 less than 100 for interventions when the result becomes available. Then they will go see a doctor who will perform full clinical assessment, and if there's no medical concern, the doctor will prescribe ART for 2 weeks, and then we'll ask them to come back for follow-up visits. Again, these are the clinical exclusion criteria that I already talked about earlier. The nurse will then order the lab test and schedule for the follow-up visit. And remember that the patients don't actually need to get their blood drawn again because this step was already done during the process of blood collection for the confirmatory test for HIV and CD4. So what happens after you initiate ART? The linkage to care happens at visit 2, and this is very important as we only provide short-term ART. We will initiate the process of linking our patients to their preferred long-term care site, and this will be done within the 2 weeks time frame after the initiation. However, many of our patients choose not to use their health insurance to cover their medication expenses, but decide to actually purchase their own medication at the private clinic. At the Anonymous Clinic, we also have the after hour so that acts like a private clinic. So if this is the case, they will forego this visit. Follow-up visit with the doctor happens at visit 3, which is 2 weeks after the initial ART treatment. So after reviewing the baseline results and assess ART adherence and complications from ART, if everything looks normal, the doctor will prescribe another 1 to 2 months of ART, depending on the status of the transferring of the registered hospital, and will initiate the referral process to the long-term care site. So the principle underlying same-day ART here, and I also borrowed this from Dr. Diane Heffler, is the warm hands-offs. What that means, it means that we will accompany the patients during each of these steps. And for the last visit, the navigator will actually go with our patients to see the primary care provider at the registered hospital. And this is the last step of the service. And after this, the navigator will contact our patients through the line application or phone call periodically. So how do we do? From July of last year until December 2017, 1,062 people tested positive at the anonymous clinic, and among those, 922 were eligible for same-day ART. So among those who are eligible, the acceptability is 90% overall, with slightly higher acceptability for newly diagnosed when compared to the re-engaged group. And these are the clinical characteristics among those who entered the programs. As you can see, the majority of the patients fell within the normal range. The most concerning aspect for us is syphilis. As you can see, 1 in 4 people who tested positive for HIV also tested positive for syphilis. And I think our team would need to go back and discuss how we could actually revise the protocol so that syphilis treatment could be done in a timely manner. Also for creatinine level, we do call back our patients who are creatinine clearance is lower than 60 because one of the drugs we use is TDF. The majority of our patients have CD4 level greater than 200, with the highest concentration around 201 to 350. Okay, mean length. This graph really shows the impact that this program has on linking the patients to ART initiation. I mean, the first set of graph, those 3, represents the mean days from HIV diagnosis to care engagement. What that means is that the first time they learned of their HIV status until the time they met with the navigator and agreed to enter same-day ART. The mean days for the total is 102.4 days, with 1.1 days for newly diagnosed and 263 days for re-engaged. The second set is the mean days from when they met with the navigator until the first time they took their medications. And as you can see, the mean days for overall groups is 1.2 days, and it's 1.3 for newly diagnosed and 1.1 for re-engaged. The next step that we are trying to do is that we are trying to measure this in terms of hours because a lot of our patients have 0 days, which is really hard for us to compute. So this second set may be not depict the accuracy of the reality.
2 minutes?
Yeah. So this is the graph represents, which is what this graph represents. As you can see, that we were able to initiate ART on the same day of care engagement for most of our patients, and if we couldn't, we tried to do it no later than 72 hours or 7 days. Challenges, linkage to care. After 2 months and a half, we assess if our patients have been referred to long-term care site, and it is 88.2%. And for now, 12 people from our cohorts have viral load undetectable. So challenges, I just want to echo from what Dr. Nitya and Dr. Baker said. For us to successfully achieve same-day ART, we need to think about how we could redesign the system, how we can deliver the care of HIV. We need to look at the guidelines and see where we can revise it. But more importantly, we need to think outside the box, especially looking at the resources around us and see the tasks that we could decentralize, so, including utilizing the experiences and expertise from the community members themselves so that the workload is less demanding. again, the health insurance problem, like Dr. Nithya said, there's a period where, very restricted period where the patients could change their registered hospital. But then again, the reimbursement for Thailand is that the hospitals take 7 days for them to request to take the test from the health insurance and for them to approve, and another 7 days plus for them to actually get the results back, further delaying same-day treatment. So what's next? We are trying to create the package of same-day for other hospitals who are interested. So hopefully we could expand to other hospitals around Thailand this year, and we have to think about different models that would fit different contexts. Last slide. I would like to thank all the persons living with HIV. They all have been a great mentor for us. Dr. Dan Hafler, who was kind enough to share the protocol with us. This project is funded by the Thai Red Cross AIDS Research Center, as well as the USAID PEPFAR's Linkages program in FHI. But last but certainly not least, this project would not have been possible without the fierce leadership from the Panupak family, Dr. Nithya and Dr. Prapan, as well as Dr. Nipat and Dr. Pongsakorn. Thank you very much.
Excellent.